Good morning. Tim Morley from St. Francis Hospital. I'm the current MIS fellow there, and I'm actually presenting data from our Department of Acute Care Surgery and our management strategy for acute cholecystitis. One of our providers has industry relationships that are not relevant to this work, and we receive no funding for this work. Me personally and the remaining of our authors have no disclosures. So acute cholecystitis, too far. This is a common clinical problem with estimates of about 200,000 new cases each year. We have a relatively good standard of care with early antibiotic treatment and early minimally invasive cholecystectomy, and actually has pretty good outcomes. Low morbidity, low mortality, and usually a pretty prompt discharge, except when we don't. There are some really uncommon but challenging scenarios often encountered, especially in the acute care world, related to both patient factors, cardiovascular disease, diabetes, other comorbidities, and disease severity, where the extent of inflammation or other organ failure result in a really tough decision to make. When the general principle of antibiotics and early cholecystectomy are applied to these patients, you can have some optimal outcomes: higher rates of bile duct injury, higher rates of conversion to subtotal or open cholecystectomy, and this actually impacts survival. So what do we do now? Well, the 2018 Tokyo guidelines, through a series of publications, provide a series of flow sheets to help manage this. And this is actually interesting because it assesses both the severity of disease as well as patient-related factors, including comorbidities through CCI and ASA. In patients with grade 2 or moderate disease, you can see that all but a subset on the bottom are healthy enough and generally recommended to undergo urgent laparoscopic cholecystectomy. It's only the patients with comorbid disease, which they define as a Charlson index of 6 or greater, or an ASA of 3 or greater, who are recommended to undergo percutaneous drainage in the early setting with a delayed cholecystectomy. However, as grade of disease becomes more severe, you can see that all roads generally lead toward early drainage, except in the most ideal candidates. So this is really helpful. There's some great evidence-based guidelines to guide next steps, but the question becomes, well, how do you get that done? I think our institution historically recognized these suboptimal outcomes, and when we applied those same principles, found that we were draining more people. How do you manage those drains? How long do you follow them? And how do you ultimately get them to the ideal destination therapy? So we developed an institutional algorithm to address this, and that's what the rest of this talk will focus on. It has been and currently is our practice to offer upfront antibiotic therapy and surgery to the ideal candidates and candidates who are at acceptable risk. However, patients who are at high risk for surgical complications and have high-grade disease by the same principles outlined in the Tokyo guidelines, these are referred to interventional radiology for percutaneous drainage done by ultrasound, and then followed in the office 3 to 4 weeks later. Patients who are asymptomatic at that time are referred for a through-the-tube cholangiogram, and if negative or ducts are open, the tube is clamped. They're sent home and they're scheduled for a minimally invasive cholecystectomy about 6 or 8 weeks after the tube is placed. If at any point these criteria are not met, they shift over to the left column here, where they either undergo CT scan, but ultimately have an office visit to decide, do we need more antibiotics? Do we need further workup? Have we excluded anything else that might be going on in terms of other disease processes with the goal of getting them to minimally invasive cholecystectomy? Here are our results. Over a 42-month study period, 29 patients ultimately entered the algorithm under the percutaneous drainage pathway. These patients were generally older, more likely to be male, and had, for this conference, a relatively low BMI. The rest of the demographics actually reflect our patient population in Hartford. They were sick with a CCI of 6, most likely had grade 2 disease, had an interval actually of about 11 weeks to surgery. Most were done robotically. Operative time was generally under 2 hours, and most were discharged the same day. Outcomes from utilizing this algorithm were quite good. Our primary outcome was a conversion to subtotal or open cholecystectomy, which we had 1 still performed laparoscopically. And the secondary outcomes on the left here highlight some of the other morbidity, but I think it's important to note there were 0 30-day mortalities and 0 bile duct injuries. When we compared that to historical literature, we found that our series was rather small with only 29 patients, but we got 100% of those patients through a completion cholecystectomy with no patients lost to follow-up. Our conversion rate was much lower than reported. Our mortality rate was 0, but our morbidity rate was quite high relative to the literature. And I think when you go back and look and see why that might be, you recognize that the technical aspects of bile leak and hemorrhage are still quite low. I'll highlight again that there were no mortalities and no bile duct injuries. And we included this grab bag category of other postoperative morbidity, and we did that to make sure that anybody who stayed more than day stay surgery had their morbidity captured in some way. We then delineated a little further the laparoscopic and robotic assisted groups. The laparoscopic group was, there were more males in the laparoscopic group. The robotic group was actually sicker, almost significantly so. And operative times were generally comparable. And outcomes were quite good in both, but far more in the laparoscopic group, with only postoperative ileus and postoperative pain higher in the robotic group. I mean, there are significant limitations to this study. And this is a single center, it's a small series, it's retrospective in nature, and it's underpowered. These are relatively rare complications, and we only have 29 patients. Our literature comparison was done by keyword search, not by meta-analysis or systematic review, and I think there's a lot of opportunity to improve on that, and we lack long-term follow-up greater than 30 days. It's also hard being a single institution to know how generalizable this is to other institutions and other acute care or MIS type practices. You know, I think too, this is a novel algorithm for how to adopt the Tokyo guidelines into practice, but this is in no way a novel concept. But by implementing this, we were able to take 29 patients, all of them through an algorithm to minimally invasive cholecystectomy in a way that's safe, with acceptable morbidity, no mortalities, and no feared common bile duct injuries. And it's effective because we got all of them there with a low conversion rate. I think when we talk about next steps, we can't dismiss the benefit that was alluded to but not proven in the robotic group, and this could be attributed to a better view with a better camera and adjuncts like ICG, which we don't have available on our laparoscopic platform. And again, generalizability relies on a lot. Your team buy-in, your institutional resources from radiology, your clinic to get these patients through, and access to all of your MIS platforms. And I think we need bigger numbers and a better comparison to do that. But as a fellow, I also have to think about my own practice and how I take the lessons learned from this and adopt them not just where I am now, but also where I'm headed. And with that, I will take any questions. Thank you.